So very good morning to this star-studded show of STAR, and we have this lens-based refractive surgery. This is the future. So may I now invite the panelist for this wonderful show. I am Dr. Sonu Goyal. I'll be moderating, and we have Dr. Arun Jain from PGI to be on the dais. Welcome, sir. Dr. Purendra Bhasin. Dr. KP Kudlu would shortly join us, and I request Dr. Vavekar to please be on the stage. So welcome you all, and hope to have a lovely clinical academical meeting where we can address all the queries. And to begin with, we have Dr. Anant. Okay. So, Collamer, a game changer phakic IL material. So, we have Dr. Anant who will be talking on this. So, all to you, Anant. And Dr. Anant is a senior phaco-refractive surgeon at the Lotus Eye Hospital and Institute, and he runs a chain, and he's a high volume prolific refractive and an ICL surgeon. And all to you, Anant.
Thank you, sir. Good morning, everyone. At the outset, I would like to thank Star Surgical for considering me for this session. I'll be speaking on Collamer, a game changer phakic IOL material. If I just say Collamer is all alone in the game of phakic, it would not be an exaggerated statement. If I do not say it, it can be understatement also. I'm just high volume surgeon and speaker trainer also for the surgery. If you speak to any phakic IOL surgeon, if you ask them, they will always say ICL surgery is one of the most rewarding surgery out of all the anti-segment surgeries they do. This surgery is the only one which gives the fastest visual recovery. You'll see absolutely quiet eye, non-inflamed eye. You see the post-op, it's absolutely quiet eye. And one of the most easy surgeries to perform, and you'll always have least complication with this surgery. All this happens only because of this material, Collamer. I owe all the success of phakic surgery to this material, Collamer. Collamer means it's biocompatible. It is almost synonymous with this word. It's a copolymer. It's a copolymer of 0.3% porcelain collagen and 60% hemocollamer. It is hydrophilic in nature, almost 35% water content. It has got an inbuilt UV blocking chromophore. You see the refractive index here, it's around 1.45. The normal natural crystalline lens is around 1.42. It is slightly higher when compared to normal crystalline lens. No other material will have so much of light transmission. It is almost 99% light transmission. These are all the beauties of Collamer, because of which, of its hydrophilic nature, it is very soft and flexible. Normally, all human beings, we do have fibronectin in our aqueous. This fibronectin has got a special affinity for the collagen which is present in the Collamer. This gets adhered and forms a coat. Since it's forming a coat on the Collamer, the anterior chamber of eye doesn't detect this as a foreign body. That's the reason we absolutely get a non-inflamed eye or a non-red eye post-surgery. This is the most important thing. And secondly, the collagen of this Collamer is negatively charged. It always repels the proteins which are present in the aqueous. It repels, so you never get the protein deposition. 20 years down the line, the patients which have been operated for ICL 20 years back, when we are explanting now, you can see the lens as crystal clear. The proteins are never deposited at all. Unlike non-Collamer materials, you do have tendency to get the deposition. As I mentioned, the refractive index is slightly higher than the normal refractive index of crystalline lens. You don't get any deflection. As the material changes, for example, non-Collamer or acrylic material, the refractive index goes more than 1.48, chromatic aberrations are induced. That itself can cause dissatisfied vision, but that doesn't happen with Collamer. And we are making very peripheral incisions. We are not inducing any aberration. Prolet shape is maintained, and light deflection do not happen. Coming on to the safety and efficacy, even without central flow, the amount of cataract tendency was very minimal. With the advent of central flow technology, the incidence has literally come down. Coming on to safety, in a quick hands, hardly surgery takes around 1 to 2 minutes. It's a quick time surgery. No significant endothelial cell loss has been documented. If you look into international literature also, there is no loss of endothelial cells. Wide range of treatment is available until -10 to -18 lenses are available. Other advantages, not only for myopics patients who are not suitable for LASIK thin corneas, post C3R patients, we have done it in post keratoplasty patients also, post LASIK regression patients where you don't want to do LASIK, yes, this gives. Coming on to visual recovery time, even if I do smile, that wow factor sometimes lacks. There will be pain, photophobia, irritation following femtolasic or LASIK, but with this eye, visual recovery is very fast. We do not use intracameral pilocarpine also, there will be no spasm. Patient will be able to see the good 600 and better within hours of surgery. So quantity, quality is good, so patients are happy. Any topical phacosurgeon can do this surgery. There is no need for extra investment like femto or excimer. The results are not dependent on humidity or temperature. Even doctors are happy. Any topical phacosurgeon can start doing colamer in this thing. As I mentioned, complications are very minimal after the invent of central flow. IOP is never issue. Cataract, as I mentioned, is never issue. Endothelium, TAS, we have well-equipped theatre centers, so never happens. Because of all these advantages, lakhs of colamer has been implanted worldwide. So just to summarize, it's a biocompatible material, quality of vision is supreme, it's easy to handle, hydrophilic in nature, and efficacy, tolerance, safety has been proven over years. Thank you.
Thank you, Anand, for that wonderful talk. So, any questions for Dr. Anand? So, from the panelist.
Can you explain about central flow? That hole gives rings.
Gives?
A ring around the light at night.
Yeah, 360-degree micron hole rings appearance is experienced by few of the patients in the first few weeks, hardly 1 to 2 weeks. Later on, it doesn't cause any problem to the patient, sir. That's what I've seen.
And they get adjusted within less than 1 month.
Hardly 2 to 3 weeks.
Yeah.
Just to again reiterate the point that you spoke about, very well spoke about the biocompatibility of this material. So for example, like we recently performed somebody who had -30 diopters. Instead of performing, you know that now there are a lot of manufacturers who can actually customize the lenses for you and do -20, 25, 30. But we prefer to perform the STAR ICL along with the SMILE as the bioptics for them, because we know that in long term, the biocompatibility, the possibility of very, very less incidence of cataract will be hugely in favor of patients. So I think this point of the material being unique really helps our patients in long term.
Yeah, that's what we do also. Whenever the colamer doesn't support the high power, I make a LASIK flap, go ahead with ICL, check the residual power, lift the flap 2 or 3 days later and correct the power.
Absolutely.
What has been your personal experience with the colamer vis-a-vis the competition, the hydrophilic or hydrophobic, whatever they say, in terms of the cataract? Because I believe cataract is the only, in the series, the biggest complication with the phakic lenses so far. So what has been your personal experience with the colamer? Do you feel that the colamer is a little more safer and a little more biocompatible?
I personally feel it's very much safer, sir. Because I'm doing colamer since last 8 to 9 years. I've seen my boss cases done since 2007 or 8. Hardly 1 or 2 cases have undergone cataract surgery. In my cases, I could see 1 or 2 touch in the side which has never progressed. My individual ICL cases last 7-8 years, till date, I have not done a cataract surgery, till date.
So
colamer.
Can we take home this message that colamer is much more biocompatible in terms of, causing these complications in terms of cataract and
low volt of 160, 180, we are able to see that still patients are doing good.
So do you think that the V4C, the central hole, also plays an important role in this with the, the physiological movement of the aqueous through the...
Could be, sir. That's also not, but looking back to the older ICL patients who are even before the invent of central flow also, the incidence of cataract is literally very minimal.
And the second best thing that I believe is that the moment you want to explant these lenses, the lens exactly comes to the same incision what you injected, vis-a-vis, these stiffer material. So thank you, Anand. And now we have none other than Professor Dr. Sudarshan Khokar, who will be enlightening, the pre-operative evaluation, the sizing, and let us gain to his immense experience from the RPC. And year after year, he has been teaching us and making us more knowledgeable on this. All to you, Professor Khokar, sir.
Thank you, Sonu. And Sonu doesn't sing. Do you sing? Goel Nigam. Okay.
Unfortunately, no.
But yeah, so let's start the ICL. Now, ICL, as we're talking about, is one of the surgery which is one of the best as of now for the refractive purpose, right? The anxiety is how to size it. So I think that's the only thing I'm going to touch about, sizing. Because we have a galaxy of surgeons here. Dr. Chaudhary is here, his son is here, and I mean, everybody is a great surgeon here. So we'll stick to the sizing. So my anxiety was how to do the sizing. Can I see the raise of hands of people who put in ICLs here, please? Can I see the raise of hands? Oh, lovely, full house. So the commonest size which you put is either 12.6 or 13.2. Is it right? Can I see the raise of hands, please? Okay, so 90% of the lenses are 12.6 or 13.2. All right. So how do we come to that, and why do we have 4 sizes only? So let's make it a little funny now. Okay. The first thing is whenever you try to do this patient, I think that's for the opening for this symposia. No surgery. Any kind of risk I don't want to risk any in these patients at all. Not even a 0.001, because these patients are 20/20 or 6/6 with the glasses or contact lenses. So please don't touch it if you're not confident, if you're not sure that what you're going to do. So no complications is what we want. And second is, the myopia is not going to stop. So if there's a retinal changes in the myopia at the back, please tell the patient he still has to come up, follow for the retina checkups every 6 months or only, depending on whatever the pre-status is. And if they have a hole in the retina, please laser it, plug it, check it in another 4 to 6 weeks, then only go in for these intraocular surgery. Okay. All right, so this, if you see the first chart on the right side, on the top, is the average height of the male. I'm talking to the males, it holds true for the females also. That's 2019. So you see, there's a variation. There's lots of variation. So if you want to measure, buy a shirt from the market, what are you going to check? You're going to check the collar size, you can do the chest size, you do the waist, you do the shoulder, you see the sleeves, and then you see the length. Okay? Fine. So this is what average male is. Mr. Average in 1961 was something, in 2017 it's changed. So it's changing. But fortunately, the eye size does not change that much. Once the guy becomes mature, whatever the size is there, it stays. So because there's a variation, you have a variation. So if you might be lucky to get a shirt ready-made which comes and fits you, you might have a cuff which is longer, you might have a collar which is not fitting you well, whereas in the ICLs, even if there's a mismatch of a few millimeter here and there, it's not going to worry much. I'm going to show you with the experimental things, which I'm going to show you some here. Okay, so if you see, this is what the ICLs are. You've got a 4 sizes for the myopes and 4 for the hyperopes. The one in the yellow are myopes and the one in the orange are the hyperopes. So smaller lenses for hyperopes and the bigger lenses for the myopes. All right. So when the patient comes to us, what are the pre-op assessment? First, you do a good refraction. If your refraction is wrong and that's what you feed onto the sheet for the calculation, so garbage in will be a garbage out. So you have to be very accurate about the refraction. Please do a duochrome test in your own hands in the at least first 100 patients, so that you don't have any problem, or you get a good optometrist for that. Then comes the sizing. So sizing, why is the issue about sizing? Because what you measure is white to white, and you're putting the lens in the sulcus. So you need to have formulas which tells you that if this is the white to white, what is going to be the sulcus. So if you go and see, and the best way of doing it is a UBM, but and most of the people might not be having a UBM to measure sulcus to sulcus. But certain patients in which you find there's an anomaly on measuring with the calipers and with the OpScan or a pentacam, there's a difference. In those patients, you might have to come down to the UBM to pick up the actual size of the sulcus. So white to white, what the dictum says, it's if you say the white to white, you add 0.244 to it becomes the sulcus to sulcus. Is it correct? And how have we come to this? There could be undulation and anatomical changes behind the iris which you can't see. So it might not be true for all the patients. Okay, so this is what the sulcus looks like if you see from the back, and there could be undulations in the periphery which can cause a problem. So this is the article which I'm quoting. This is an article by Pope and et al., which JCRS 2000, and there were two people, Fia and Pope. So what they did was they measured the white to white, angle to angle, and sulcus to sulcus in these patients. The average they found was 11.7, 11.9, and 11.2. But how did they reach to this conclusion was they used a UBM probe of 50 megahertz, and 50 megahertz probe will give you a big image. So you have to have 3 images put together to actually make a collage and measure it. So this is what they used to do. So they have to put all these 3 images. So the error by putting these 3 images on each other was itself more than a 0.75. Meaning that this article you just cannot use for your extrapolation to the actual size. All right. The better would have been if they used the 35 megahertz, which gives you through and through. If you can see here, through and through, this can be measured with a 35 megahertz probe only. Okay. So the sizing still remains a challenge. That's why I'm sitting here. You can try any of these modes. We found OpScan was a very good machine which has a slit scheme technology, so it used to start scanning from one side to the other, and you give you very accurate data. I don't know why the machine has gone out of repute and it's not been available anymore. They have Pentacam, but Pentacam always gives you a little higher number, so your lens size might differ. So the caliper down here is very good to measure. Even my golf ball, if I put there, it'll give me a good accurate measurement. Okay. So what you need to do is, whatever machine you're using, you have to keep calibrating it again and again to check that you don't have any errors in these ones. And there should not be too much difference in both the eyes. If there's a difference, then I think the mechanical measurement is the best, or you can go for a UBM measurement on a sulcus to sulcus on a UBM, a 35 megahertz UBM. Okay. All right, we come here. So why only 4 sizes? Is the question we can ask the company. So there was a study which they did in which they actually picked up people from 10 years to 80 years of age, a huge number of patients in this one, and they found out that the average diameter was 11.7 plus minus 0.41, and this is a study in which they found out the average male size varies from 11.4 to 12.5 for the males and 10.7 to 12.58 for the females. So if this is what they could find, they actually got it in the 2 standard deviations. So if you can come into this range, 95% of your 99% of your population will actually fall into this one. So it's a good study. So the 4 lenses are good enough actually. Okay, so what happens if the lens size is smaller, it will have lesser vault, but it can cause cataract. If it's a higher one, you have a higher vault. So what happens? Let's see what happens. Okay, so all right, let's go there. Now this is one of the chart which was given to us about 10 years back, in which they said that the ideal vaulting is between 250 to 750. I would like to change it now. My ideal vaulting should be between 500 to 1000. I want it a little higher vault. So all these surgeons, if you have an option to pick up a lens, please go for one which is higher. With a V4C model with a hole in the center, it's not going to make any difference, and your high vault will sustain for longer. Each year you're going to lose about 25 to 28 microns of the depth of the vault. So if you got a little higher vault, it'll help you better. So the patient, by the time he comes to the cataract age, he'll still be having a vault around a 250, which is good enough. Okay, so these are some examples of the good vaults. I think all of you know that. So let's come to the ones which I want to talk about. So this was a slides given by the company, which they picked up the lens and they did some mechanical tests. So see, this lens is a 12.6, a 10.5 is the power. And if I do a compression 1 millimeter extra, 1 millimeter, that means 12.6 becomes 13.6. Which is huge. Okay, so this is what happens. This much is a high vault. You can appreciate the vault. So what happens with the vault going up? So if you see the force and the vaulting, you realize that for each 0.1, it's only 5 milligram, and it's 0.11 millimeter, which is higher. So if you have a 0.5 millimeter extra lens, it's not going to make much of a difference. Okay. So this is the article which say that every year you're going to lose some vault. So I already told you about that. So I'll skip it. So your aim has to be to pick up the highest possible vaulting without having a defect in the refraction. That means if the lens goes too much anterior, your power might change. For a hyperopic lens, if it goes more in the front, it becomes more effective. So you have to reduce the power by 0.25, and if it's a myopic, you go the other way around. So this is one of the example I'll give you. This patient was done in 2008, and now it's already more than 14 years now. So we put a 21.5 diopter and 120 was used in this patient. Now the patient is 6'9", there's a peripheral touch, and this was not a V4C model. So this patient is actually touching the periphery, but the central part is a vaulting about a 200, 180 to 200, a very low vault in the center. But the patient doesn't want a surgery, but there's a peripheral touch, there's a cataract there, it's not progressive, it's localized to that area, and vision is 6'9", so we're just following this patient up. Okay, so when you calculate the power, what do? There are only 2 things which you can measure actually. You do an anterior chamber depth anything less than 2.5 and 4.5, you can't put an implant because the machine is not going to take it. So if it's more than 4.5, say 4.6 or 4.7, you have to still put 4.5 only, otherwise the machine won't take it. And the second is white to white, between 10 and 13.5. Okay, so if your corneal diameters are less than 10.5 millimeter and more than 13, please do not buy a ready-made shirt. Do not put ICL for these patients because we don't have any lenses. And the ACD is less than 2.8. So the answer is no. Okay, now we got what? 11.11, 11.5, 12 and 12.5, and that's what we have. So these four groups with two parameters of ACD which is less than 3 and more than 3. So if you can put these together, you can have this algorithm and you can actually pick up the lenses which you want. So if, for example, if it's a 11 diopter across less than 3 and more than 3 millimeter, that's a ACD. From the endothelium. Okay. So if I put a 12.1, it will be a high wall for me. If I put a one higher than that, it will be a moderate. It will be low volt actually. But if I have 11.5, I can have two options here. I can have a 12.6 with a high volt and 12.1. Basically, we have got 4 lenses to play around with, and most of the time you have confusion with 2 powers, which is 12.6 or 13.2. Majority of them, that's the issue. In my own data, which I checked for the last, I think, 15 years, 96% of the patients were either 12.6 or a 13.2, and we have not explanted any of the lenses because of a poor volt. I'll just take 2 minutes more. So similarly, you can go see this data. I think you know this one. I've been presenting all over. So if the 12.5 is across less than 3, you have a moderate with a 13.2, and if you go for the high volt, then you have a 13.7, which is the maximum. So if your demand is more than 13.7, please do not put an implant in these ones. This is not going to do well in any of the people. So if you have a myopic, you can actually calculate the power 0.25 higher, because minus number going away from the pupil, from the lens area in front will have less power. So you put 0.25 extra, and for the hyperopes, you can reduce it by 0.25. Okay, so this is what I'm going to show. If you put the lenses properly, a volt is going to be fine. And even if the volt is a 0.5 up and down, it actually is not going to cause any problem in these patients. Thank you very much.
Thank you, sir, for that wonderful talk. Any questions for Professor Dr. Khokhar?
Dr. Khokhar,
So before
Sure.
what is the minimum volt you will like to leave, and what is the maximum volt which you are going to, which is without the rise in intraocular pressure which you are going to leave?
So I think all these patients, you're going to do a gonioscopy before the surgery. So if your patient's an angle closure, a prone angle closure, you're not putting implants in these ones. Okay. So I'm taking the factor away. So what you're saying is, because of the volt, how much is the angle closure happening? That's what is the question, right? The pressure going up because of the angle occlusion.
Pressure is normal.
Okay, if the
only
pressure
the volt is high.
It doesn't make a difference.
Only
If the volt is good,
high,
the pressure not going up, only the power can change a little bit, and that you can adjust beforehand. So if I'm picking up at 13.2,
Now what is the
Vaulting?
maximum volt which you are going to say without any rise in
okay,
intraocular
I'm following the
pressure?
patient with the 1000 plus 1100 volt. Also, I'm following the patient for last 4 years, and nothing has happened, especially with V4C. And the volt is going to go less every 28 micron every year. So you follow them, and it's going to go less. So it's not, doesn't make a difference. So don't be in a panic to take the lens out if the volt is high. If the pressures are good and the pupil is constricting well, if you don't have a Urot-Zavalia kind of picture, then of course you can leave the lens alone. And my take is that you keep it 500 to 1000 volt. Don't stick to 250 to 750, which was early recommended.
And what is the lowest volt which you will?
250 is the lowest.
No.
Okay. I'm following this
If
patient.
it is 180, 170, 160 volt.
With V4C model, you can have a liberty with a hole in the center. You can have a liberty of going little low also. Now, these are the patients which are in the extreme. So that means if you really, the kid is saying you want to have this shirt only and it's available in this size only, and he doesn't want to wait. He doesn't want to go to a tailor to get a thing made. Then you have to fold the sleeves, you have to adjust to the shirt. But yes, anything between, even if it's 150 micron with the central hole lens V4C, we have followed these patients for 5 years, nothing happens to these ones.
So, Dr. Khokhar, you still use anterior crystalline lens rise for varying your size of ICL in borderline cases were like 11.6 or 11.7, because that makes a different size.
I think that's a very good question he said. Now what he said is a lens rise. Lens rise means we're looking for the straight, and for the near, the lens changes the dimension and the lens also gets pushed up. So there was a study in which they found out that the lens rise happens, it's similar. Even if the patient is looking straight for the near and the distance, the rise does not make much difference. Even that article which says 28 micron, it changes, talks about the lens dynamics and rise. what Dr. Arun is trying to say, that if you have a borderline cases, those are the only cases where you can actually get stuck sometimes. But for the majority of the patient, if you're right in the middle with a true standard deviation on the side in the Gaussian curve, I think 99% you'll get away with that. So you don't panic. Please wait for these patients and these lenses settle down. Yeah.
Yeah.
So I think there is.
I have one question.
Sure.
Of course, we got the message from here that all these ICL with the central hole, the chances of cataract is negligible.
Sorry.
Can you
Can you
please
use the mic,
switch off the.
Guys, can you please people switch off your cell phones for 10 minutes? Because after that you can put it on. Anyway, for the session, I'm sorry. Okay. Sanjay, please.
So, we got this impression that with ICLs with a central hole, the incidence of cataract is almost negligible.
Yeah.
However, you showed us a slide.
Mic, huh?
You showed us a slide.
Yeah.
Where the old version, V4,
Yeah.
without the central hole, there was a peripheral cataract developing. Now, for a lot of us who still wonder whether we should intervene in such a cataract, take out the lens, and will the cataract progression stop? Or we just let it be and let it go on towards full cataract and remove the cataract?
Okay, I think that's a very good question. Now, what happens is when you see a vault, what do you mean by vault? Vault means that you can't flatten the lens on a horizontal platform. It has its rays in the center. So the periphery is where the lens is touching in that patient which I showed you. And we gave the option to the patient. She didn't want a surgery and she's 6-9 years, so we're following it up. They will not form a central cataract, and these cataracts do not progress. They stay localized to that area only. They do not progress. Something like if you do a peripheral iodectomy in this patient of a glaucoma patient whose angles are shallow, you might have a little cataract forming there when you are very aggressive in making the hole. Especially in the Indian irises, you make a hole, it's small, you want to make it bigger. You can have a localized cataract, but that does not progress down all the way. Is that clear? Okay, anybody else?
So just last two questions for the
Sure.
interest of the general audience. Give me two equipments, one for the white to white and one for the ACD, which I want to purchase so that, I can be rest assured that I get the most reliable or the accurate measurements. So number one is white to white, which is your most, which you say is the reliable tool to measure white to white.
I think the digital caliper is the best as of now. Earlier I had an OpScan system, which was a scanning slit beam. I don't know why they stopped. Now all these pentacam with the sheen flux and all those, they always over-calculate. So you can't actually rely on that. So if your digital caliper, which comes for, I think, 5,000 rupees, you can pick up these Japanese digital calipers. They work wonderfully well, which I showed you there. Pentacam we do for remeasuring, reassessment of those ones. Otherwise, I think a simple caliper is good enough. Anterior chamber depth, ultrasonic is the need of the hour. That's the best. You can't use the sound there. You can't use the OCT because there will be so much variation in that one. So ultrasonic depth and cornea thickness with that only, and remove the cornea thickness from the entire, and you use a digital caliper.
So nothing fancy required to start an ICL practice.
Yeah.
A simple caliper is what is required, and then anterior chamber depth, what he said, measuring with an ultrasound.
Yeah.
Or do you think pentacam also is inaccurate in measuring the ACDs?
See, it can help you. See what happens now, once you're doing your ultrasonic, and then you can assess with that. So if you can, the problem happens when there's a difference in the anterior and the posterior growth of the eyes. I get sometimes eyes which are nanophthalmic. Those are the one, and the curvature is different. In those ones, the white to white is never going to be giving a good, accurate assessment of the sulcus to sulcus. So those are the patients in which I have a UBM of 35 megahertz where I use it. I use it not very often. So what I started doing, I was doing in all the patients. Then I realized most of my data from the UBM is coming the same. But in certain set, maybe 1 to 2% of patient in which there's a anatomical difference. Nanophthalmic eye, a growth in the anterior posterior is not going hand in hand. If the patient is at 13, 14, 15 myopia and the axial length is not too much, so that means the chamber depth is more in this and not at the posterior. Those are the patients, if you can use a UBM in those ones, you will never fail.
Thank you very much, sir. So now we have Professor Dr. Tetial, and he'll be sharing his expert tips and tricks for the toric ICL implantation. Thank you, sir, for being with us. And it's an honor to have you here. So all to sir.
Thank you very much, Sonu, for a kind invitation, and all the chairperson on the dais. And my dear friends and colleagues, very good afternoon to all of you. And this is what star people asked me to talk about, the toric ICL. And looking back, the initial two presentations were absolutely important for a starting ICL practice, ICL surgery, and getting a good outcome. And Dr. Sudarshan really made very, very clear what are those important points which makes the ICL perfectly oriented in a patient's eye and gives a perfect vision also. And that holds true for a surgery for a toric ICL is not different, except for you have a cylindrical power which has to be placed in a desired axis for a patient. Otherwise, workup of this patient, the amount of requirement is similar, the digital caliper or one optical device to have a wide to wide, the AC depth, everything is almost similar. This is what we talked about, different sizes, very clearly talked about. Only thing is important for us to, whenever we do a surgery like this, which is a refractive surgery, the pre-selection of these patient counseling, which we talked about, has to be absolutely perfect. Sometimes we don't get the desired outcome in these patients, what we normally see, especially with the toric lenses, which may give you some sort of a residual cylinder, which may not give a good vision to patients sometimes. So this has little more accuracy is required in these patients while placing the ICL in a particular axis. So I would say meticulous surgery is important, especially for axis orientation. Maybe a place like ours in RP Center where you have IOCT, which we are discussing in terms of the bolt happening. You can measure the bolt on the table itself. Suppose you have a less than 100 bolt coming up, or you have a 1400 bolt coming up. This may only happen if your pre-operative assessment were not correct. Normally in today's scenario, you don't get these scenario at all. As Dr. Sudarshan talked about, thousands of cases we have done, yet to disimplant or take out the lens from the anterior chamber is not required. That means the assessment part has been perfectly done by us nowadays in recent time. I had one publication which came up in, I think, around 6-7 years back, where we realized that with the new generation ICLs, the cataract and glaucoma part is away. Because initial, if you see the results, most of the explantation were because of these two reasons, glaucoma and cataract. In recent time, they are in a past now, and the most important reason for explantation is posterior segment surgery because of some complication happening like detachment, other thing which Dr. Sudarshan talked about. These parameters, you just know these things. ICL sizing we talked about. Basically, calculation of a toric power is important, which you have to give a refractive power to the company, and they'll calculate for you through their online calculator, and you have a different ordering system with them. You have to confirm their whatever reports they come out with the refraction, and then implant lens in a horizontal axis as desired. So basically you have a astigmatism calculation in terms of refractive astigmatism has to be calculated there, the steeper axis should be there, and lens should be rotated to a desired axis. The recommendation is don't go beyond 22.5 degree away from the central 180 degree, and I think mainly because the rotation will be difficult intraoperatively in some cases, and the sulcus diameter is such that it may not be suitable. It has to be less than 2/3 of 1 clock hours away from the central axis in these cases. And this is just example of one of patient. You can see one right eye, if you see here, 3.5 diopter spherical, 1.5 minus 1.5 diopter cylinder, 40 degrees. And this is the other parameters. So if you have this refraction, what would be the ICL power which needs to be done for this power? So you can see you have this target lens will be now minus 5.5 and plus 1.5 cylinder, 130 degrees, because you have to transport into the plus cylinder in these cases. The actual requirement will be this particular parameter for this toric ICL, but lens order will be a different. So you have a 5.5 spherical and cylinder same, but axis now at 152 in that particular order lens. So you have to change the orientation for the implantation. That's basically the difference between the IOL axis or ICL refractive axis and the amount of rotation needed will be dividing the target axis now, which is as per the ordered lens. In this particular case, it will be around 22.5 degrees from the central area. So this is the diagram which comes with the company's this thing, and this is a very, very critically important point. This gives an actual orientation of placement of your ICL on the table. This will be carried with you in the operation theater and put on the wall, or some assistant will tell you, okay sir, this is the rotation required for this patient. So this chart is very, very important to be taken inside the OT. So if you do a manual marking, you require a manual devices to mark the reference axis, then the actual axis of implantation should be done, and these are various devices by which you can make a reference axis, and most importantly, classically we are bubble markers can give you a 180, 0 degree and inferior markers. So if you have an image guided system, nothing better than that. That gives you the image taken from the IOL master, which can be now rearranged by taking the picture from the microscope automatically. So this is what we do a marking. The alignment is very simple. Just to show one video how we do proceed. Once you have a reference marking, you can see this is my reference marking. Then I'll put a alignment, the axis of a toric lens marking here, which is 8 degrees from the central 0, 180 degree here. The marking should be very sharp and clear. That is very important. It should not be muzzy, which we talk about in cataract surgery also is similar. So I'll make 3 openings, 2 side posts for my bimanual aspiration of viscoelastic and manipulation of lens. And I normally use 1% sodium hyaluronate for forming the AC, and lens is implanted subsequently. So if you form the AC with the sodium hyaluronate, the lens opening is much better controlled, doesn't open with a jerk, and it will not damage the surrounding structures also. And the Helon or whichever material you're using should be of that quality, it gives a clarity, no inflammation, it comes out as a bolus, and very less chances of a retained viscoelastic inside, and the glaucoma part is hardly there in these cases. So this is a technique by which you can disengage or engage the haptics behind the iris plane or pupillary plane. Then rotate the lens before you take out the viscoelastic. That is very, very important. You cannot rotate the lens after you take out the viscoelastic. That's one important point you have to learn in a toric implantation. So I have placed my lens in these axes before I had implanted, hydrate the wound and do a bimanual aspiration, which is very, very controlled aspiration of viscoelastic, and the central port also helps you to take out the whatever viscoelastic is there behind the ICL also. So these are 2 simple tricks which can be used. So if you are image guided, it is much better. Just to show the image guided, it tells you where incision has to be made. The incision size is also made. The side port marking can also be done. So once I make a similar markings here, this is how IOL is to be placed. Once I'll wet with the BSS, then put a methyl cellulose over the cartridge. Take out the lens with a cotton applicator. Then make sure it has a right orientation by looking at the one mark here, triangle, diamond mark in the right hand side corner. Then pull the lens after holding a good chunk. Don't take it the edge, otherwise you'll chip the lens. Pull it with the bimanual, both hands moving here, right and left. Make sure it doesn't get stuck into the cartridge. And same injection here, central below the viscoelastic cushion here, which will, don't allow the damage to the anterior capsular lens. Many people do hydro implantation also. I'm not very good fan of that. I'm not sure how much the fluid is going to disrupt the anterior lens capsule. So this part, you can see how easily it can be implanted inside the lens. Again, rotate the lens to the main axis of implantation before you take out the viscoelastic. This point you have to all learn, because it's very difficult to rotate the lens after you've taken out the viscoelastic. You might damage the lens anterior capsule also. With this maneuver, you can take out the entire 90% or 99% of viscoelastic with a simple antechamber manipulation. And with this, you can take out the remaining viscoelastic, which may be there little bit underneath the ICL surface through the central port. And in fact, you can go to periphery also. In the 2 holes, you can still aspirate the viscoelastic. The complete viscoelastic removal is possible if you use a sodium hyaluronate, while methyl cellulose may not give you that access. You can see this is around 550 baud, which Sudarshan was talking about, can be measured on the table also. So these type of simple techniques is also applicable to toric implantation also, like you do for a spherical lenses also. Post-op, you can always assess the IOP, visual acuity, and the residual refractive error. How do you know that your lens is well placed? You need to know the steeper axis, which is a refractive axis, and see after full dilatation where the ICL is located, and subsequently you can manipulate. There has been no instance where I had to re-rotate the ICL lenses, which is normally remains in the same place as you have placed. Unlike the IOL cataract surgery, which can rotate subsequently. That's the beauty of toric ICLs to be measured. I think to summarize, you require a very good pre-op assessment like you do for a spherical ICL, same for a toric ICLs. Only important thing is a good refraction to get a refractive amount and refractive cylinder. And whichever lens is ordered, make sure the lens is made in such a manner which you got it. Best would be a customized lens of a same power, same axis. But normally the inventory may not give you same axis lens, but that can be implanted in a way it gives you a right refractive corrections. I think if you take these few tips, you'll always be happy in our toric ICLs, because most patients will have a toric ICL requirement in refractive corrections. Thank you for your kind listening.
Thank you, sir, for that wonderful enlightening talk. A quick question, sir. For the toric ICL, when would you like to go in and, if you have a rotation of the ICL, so how do you manage that? I mean, what is your protocol? When would you like to just rotate and take the lens back to the position, or you would like to go for one size up? So what is your protocol when you find refractive surprise post-toric?
Yeah, I think what Sony is trying to highlight, which I missed, I didn't read the slide properly, because the only chance where the toric ICL might move from its axis is when the sizing is not appropriate, that to a smaller size ICL. If you have a larger size, it may not rotate, it will get fixed there. But small size, yes, sometimes it can rotate, especially in cases where you have a very deep anterior chamber, like cases where people might put for a stable keratoconus. There you may have a chance, or very, very high myopic patients sometimes. Or if you have some damage to the ICL sometimes, you may have a chipping in the ICL, which may sometimes cause a rotation happening. So never leave the chipped ICL behind, or sometimes you can put an inverse ICL also, which you may not pick up sometimes, and it can give you a different orientation. But right time would be, if you feel what is the cause. If it's a small size, then it has to be replaced and go for a new sizing lens. If you feel there is some sort of viscoelastic underneath, or there is some sort of inflammation happening, then you have to maybe dilate the pupil, see if the viscoelastic might come out, control the pressure, control the inflammation. Then you might try to re-rotate. As I said, it's very difficult to re-rotate the normal size ICLs. But you can try maybe after a few days or a week. Don't do immediately next day. Analyze the patient next day, do anti-segment OCT, see the bald, see the orientation, dilate the pupil, see what is the actual cause. If possible, you can do a UVM to see if the haptics are nicely oriented in the sulcus area. Because there have been multiple studies we have done also. All the 4 haptics may not be properly oriented in the sulcus. Some of them may get stuck in the granules, and it might get released after a few days also. It has happened. So you wait for some days, and before, don't jump for an immediate rotation.
Sir, you have done 2 paracentesis in your case. See, most of the people worried about suddenly if it is flip inside, then you have to take out, reload it, and once again continue the procedure. So if you just go in with a one blunt dialer from the paracentesis, second opening, when we start injecting, suppose if you know that it's already flipping in, with the second instrument in the other paracent, is it going to help, sir?
It will definitely go to help for those people who are doing hydro injections, where the lens can open very fast and you require a second. But as I showed, if I use a sodium hyaluronate, the lens opens very slowly, you still have a time. And most young people don't try to inject the lens fast inside the antechamber. Just see little bit how it is opening, then go slowly. Sometimes I leave the trailing haptic in the wound itself, and so that I can manipulate the lens. That's a very good trick. Don't try to inject everything inside together, and never try to place your haptics behind the pupillary plane to begin with. That is going to create more problems for you. And yes, second instrument is very, very handy. Normally I'll tell my sister, keep the second instrument ready. If I need, I'll immediately take it. And these 2 side ports are very, very handy for manipulation also. Yeah,
Dr. Sir. Last quick question from Professor Dr. Cooper, sir.
No, I just want to add on to what Dr. Tityal said, with your permission, sir.
Yeah, sure.
Okay, when you're putting the toric lenses, once they're inside, they don't rotate. He said absolutely right. So when you're putting the lens, you put in one haptic in, the leading haptic. At that time, you can rotate the lens easily to the axis without the other haptic being tucked in yet. So your leading haptic, trailing haptic is inside. And since one is in the sulcus, one is in the front of the iris, you can rotate it easily. Otherwise, it becomes very difficult to rotate. Once both the haptics are inside, which you want to rotate, you have to use both the hands. If you push it one, it will rotate. It won't rotate. It gets pushed and it comes back. It coils back. So come to the axis where you want to park the lens on the top with one haptic still on the iris, and then tuck it in there. I think with that, for the beginners, I think you will not have a problem. Otherwise, your axis might not be accurate on the table. Just a little thing.
Thank you very much, sir. Thank you for that wonderful.
Okay.
So
Yeah, in the meantime, when the next speaker
Now
sets
we
up-
have,
Okay.
yeah, please.
Just I agree with Dr. Tityal that if you inject the lens slowly, you can control the opening of the lens till the last moment. You can see it opening slowly, and one can rotate the cartridge and make it right. And second thing is, you talked about measuring the vault on the table in toric lenses. It will help if you have a second lens handy on that time. So, but it does help in cases where the error is spherical. Last month only, I had one patient where the vault was almost more than 1000. So we rotated the lens vertically on the table so that in both the eyes we had an optimal vault. So that was what I wanted to explain.
That's a very valid point. So now we have Dr. Ramamurthy, sir, and he'll be enlightening on his experience and adding confidence to the surgeons and managing some challenging situations. So all to you, sir.
Thank you, Dr. Sonu, and thanks staff for having me over in this panel. I will be talking about managing challenging situations in ICL. Normally, this is what we see routinely, well-placed ICL, well-centered, a vault of about 500 microns with excellent satisfaction as far as the patient is concerned. But there are some challenging situations, and that's what I'm going to be dealing with. This was what was being talked about last. This is a case where you can see I'm seeing that the lens is not exactly in position. I have a Varion overlay. In these cases, what I do is to just go in with the irrigation cannula through one of the side ports. Since I do it within about a week's time, you can go through the original ports itself. And with the irrigation flowing, no viscoelastic is used because sometimes just the removal of the viscoelastic itself displaces the lens. I just go in with a Sinskey hook and just gently, or the specific spatula that comes with the lens, and then gently re-rotate it so that the exact positioning of the lens is there. One caveat I would like to add here is this rotation of the lens will act only if the residual spherical equivalent of the error that's left over is almost zero. That is, if you have -1 diopter with +2 diopters of astigmatism, rotation of the lens is going to help because you are redistributing the power. But if you have a simple -0.75 diopters of cylinder, or you have a +1.5 diopters of sphere, rotation is not going to help, simply because when you are rotating the lens, there is no addition or subtraction of the power that you are doing. This is a situation which would call for a toric ICL exchange. This is a fairly old video of mine, and as you can see over here, I had a surprise of a significant amount of almost a -2 diopters cylinder left over. Possibly it was a wrong refractive value that was fed in. So what we do in this case is to go ahead and do a toric ICL exchange, because rotation of this lens is not going to help in this situation. When I have to exchange these lenses, whatever be the cost, what I do is to just expose one of the haptics out, and then with the front loading forceps or with the 10-0 forceps, go ahead and get hold of it, and with a hand-over-hand maneuver, gently bring the entire lens outside. And you can bring it out through a 2.8 millimeter or a 3 millimeter incision, and then you already have the standby lens of the correct power which needs to be loaded in so as to get an optimal result. So obviously in this expensive technology, whenever the patient has a residual error, one way to address is to do, of course, to do a laser vision correction on the corneal surface. But if there is a residual error that can be done by rotating the lens or by exchanging the lens, that would be a good way to go. And another important aspect is that we have been using cases of toric ICLs as far as iatrogenic keratoconus which have stabilized post CXL or keratoconus cases. One important factor that you need to remember is this will work only if the cone is well centered, and most importantly, if the patient is having very good visual acuity, best corrected visual acuity with spectacles. The patient requires rose scale lenses or scleral contact lenses or rigid contact lenses for the correction, is not happy with the spectacle correction. This is not implanting these lenses will not be of use, simply because the ICLs that we implant is only a replacement for the glass power and does not do anything to the corneal aberrations. So if it's a highly irregular cornea, if it's a decentered cone, the patient requires rehabilitation by contact lenses for visual acuity. Please do not try to implant a toric ICL in those situations. This is a case of iatrogenic keratoconus where we had done a sequential collagen cross-linking, subsequently did a Intacs. This was again about 7 to 8 years old, and then we went ahead and implanted a toric ICL so as to take care of the residual error that the patient had. The procedure is now, we waited for about 6 to 8 months, made sure that the power is stable, the corneal topography is quite stable. Then, of course, in these situations, is never 100% refractive accuracy that you are talking to the patients about, but it's largely debulking of the refractive error that the patient is presenting to you with, and it works quite well. We have been doing it quite routinely for patients of iatrogenic characteristics as well as keratoconus whenever it has stabilized because of aging or because of CXL, provided there is good visual recovery with spectacles. This is just the toric ICL in place with the intact segments that you can see over here. And this is another case of, this was a case of collagen cross-linkage done for keratoconus, and post intact, once the cone has quite stabilized, we went ahead and implanted a toric ICL. I just want to leave you behind with the thought that these patients who have extremes of refractive challenges, even they can be sometimes handled with toric ICLs, provided you understand the technology and use the right techniques. Sometimes even after a very well done post penetrating keratoplasty or DALK, the refractive outcome is not optimal because of the residual refractive error. In these cases, again, you can go ahead and implant a ICL or a toric ICL depending on the refractive requirement, cognizant of the fact that you are having a donor endothelium over there. So be as gentle as possible. Use dispersive viscoelastic in these situations. Most often nowadays, as Dr. Chityal mentioned, I use cohesive viscoelastic for my lens implantation because it comes out in a bolus. But this is a situation where I would use dispersive viscoelastic so as to coat the endothelium, do the surgery quite gently, and you would again find that the refractive outcome is quite satisfying for the patient. I started out with the iris clip lenses way back in 2004, and in around 2008 or 9 I shifted over to ICLs simply because what we found was a progressive drop in the endothelial cell count. Actually, the first specular microscope I essentially bought for follow-up of my phakic intraocular lens patients. This is a patient who had an iris clip lens implanted bilaterally, so almost 16 years back, but she had a progressive endothelial cell count, though she was absolutely happy with the refractive outcome. So we actually counseled her for simply for just removal of the lenses, but she was not willing to give up on the refractive advantage she had. So essentially what we did was remove the 6 millimeter overall sized optic lens. This was bilaterally done 1 week apart, and then we reduced the incision and implanted a star ICL behind the iris. And because the position of the lens, now we have almost a 10-year follow-up with this patient, and we find that the constant progression in the endothelial cell loss that was occurring with the iris clip lens has stopped, and the patient has stabilized with about 1,800 endothelial cell count and is still seeing quite well with the phakic intraocular lens in position. So obviously a posterior chamber is the right place for a phakic intraocular lens to be placed, and I'm glad that most of us have completely shifted over to that location as far as our intraocular lenses are concerned. This is a case of a posterior synechiae. The first eye, the patient had an excellent outcome, was very keen on surgical outcome for correction for this eye also. We thought that it will be easy to handle this posterior synechiae with just iris spatula. So we went ahead and implanted the lens, and then after the implantation, obviously the lens was not going in that particular area. Fortunately, it was a spherical lens, so positioning of the lens was not very important. And I went in with an iris spatula and tried to separate out the posterior synechiae, but then only I realized that it was extremely stuck to the anterior surface of the lens, and in case I had used excessive energy power, I was scared that I would rupture the anterior capsule. So I decided to just leave the lens as it is, slightly malpositioned. But I thought in case the patient is not happy with the outcome, I'll go ahead and remove the lens subsequently. As you can see in the post-operative period, this is the position of the lens. Have a follow-up of about 6 years. And the patient is still happy with the visual outcome that the patient is having with this particular lens. This is an ICL in a brittle cornea. This is very surprising. I thought it's a run-of-the-mill case, a very routine case for me. But then, as I started implanting the phakic intraocular lens, the cornea just seemed to be giving way. I thought there's something wrong with my technique, but then I realized that the cornea was somewhat very soft and it was giving way. And when I went on to my side ports, when I started doing irrigation aspiration, again those incisions also started giving way. Perhaps this is the only situation where I had to put in a suture after implanting a phakic intraocular lens. And as you can see over here, I think it's because of a situation of brittle cornea. Because the patient had a good visual outcome in the first eye, he insisted on the same surgery being done on the fellow eye, which we did 1 week later, following almost exactly the same course. So basically it's something, there's a suppleness of the cornea which is causing the problem, maybe a low corneal hysteresis. At that time we were not measuring it routinely. Maybe it was a good idea we did not do a laser vision correction on this eye, simply because the response of this eye would have also been quite different. As you can see over here, even the side ports are not closing up. I actually had to suture them up so as to close these incisions. The only good thing is the result was quite optimal. You can see this lens with good vault with good visual outcome. The significant pigment deposits that you see on the lens is because of the pigment dispersal that took place because of the handling of the iris. Last of my cases, there was some discussion on low vault and high vault. I have a gamut of cases where there has been a low vault. In this case, I think it's just about 110 microns or so. The fellow have the same patient having less than 100 microns, as you can see in AIOC2022. On the other hand, you have this extreme vault situation where there is almost 1000 microns in one eye, more than 1000 microns in the fellow eye. As far as this is just the lens being exchanged for being a high vault and anterior, what the angles zippering up. But then, most often, if the lens is clear, if the natural lens is clear, even if it's a low vault situation, I do not go ahead and exchange the lens. At the same time, even if it's a fairly high vault, if the angles are open, if the pressure is under control, we just go ahead and follow up these patients. This patient, specific patient, actually had a vault of about 1300 microns, though we found that on retrospective checking, our calculations were quite right. But then we went ahead and exchanged the lens with a smaller size lens so as to reduce the vault. And this is just a cataract post ICL, and this is just to show you that you can even use a laser platform to create a capsular rhexis. Sometimes when it's anterior subfibrotic capsule, getting a rhexis itself is a bit of a challenge. So the laser can pass through the phakic intraocular lens of the ICL and create a rhexis. Of course, because it's a fairly soft cataract, you are not too bothered about the emulsification process as such. And this is just the lens being removed and subsequently through a 2.4 millimeter incision, and subsequently the intraocular lens of the right power being implanted.
I would request you.
Thank you so much for your kind attention.
Thank you, sir, for that wonderful collection of cases. I would now request Dr. Sanjay Chaudhary, and he'll be showcasing a recorded EVO.
Sir, just before Dr. Sanjay Chaudhary starts, so you are showing about the high vault. See, what we have been practicing with the patient with a vault more than 1000, I think, then we used to rotate opposite direction, that is because always vertical white to white is more than the horizontal white to white. Normally it drops by around 200 microns post-op. Have you tried in this case?
Yes, I have tried in a couple of cases, it has worked also, but the point I wanted to leave behind was it is not just a low vault or a high vault alone, just what you measure, which should lead you on to an exchange of the lens. But in case the natural lens is absolutely clear or the anterior chamber is well formed and the angles are open, pressure is under control, these patients can even be closely followed up at 3 to 4 monthly interval, at least for initial year or two.
Thank you, sir.
Thank you, sir. All to you, Dr. Sanjay.
Okay, yes or no. So I'll just move on to this presentation. It is actually the STAR people, I think they saw this presentation somewhere live and they were very keen that it covers a lot of things which youngsters who are beginning with the ICL need to know. So it was a good idea to just take them through this recorded version to get an idea of how to go about putting an ICL.
We are doing his left eye, and the left eye has a power of 7.5 with 2.5 cylinder at an axis of 175, and the vision is 6 by 6. Now,
it's not coming clear.
We have planned this procedure for an ICL, and I'll give you the reasons why. First, when we plan the power of the ICL, this process is you transpose this power. So 7.5 with 2.5 becomes 10, 7.5, 8.5, 9.5 and 10, and then add 1 to it, so it becomes 11. So the power should be approximately 11 with plus 2.5 at an axis of 85. Now come to this screen. So the power target is 11 plus 2.5 axis 85. So you made a mental calculation that this is what the power should be. You checked with a file that this is what the power is. So you're sure you're putting in the right lens at the right power. Many a times with multiple lenses, somebody could give you the wrong lens. So this is a very good practice to make a mental calculation of what is the power that should be there. So this is a simple method. Now, the axis is 85 and the lens has come at an axis of 90. So 90 has to be rotated to 85. So come to this last one. So if 90 has to be rotated to 85, that means you have to rotate it through 5 degrees clockwise. So here is the chart which tells you that the lens has to be rotated clockwise through 5 degrees. Now we come to this chart. This is a workup sheet for ICL. If you see, the cornea's thickness is 468 in the right eye, 464 in the left eye. So it's a very thin cornea. Now come here, the ACD. ACD is 3.47. Wow, excellent. Normally it's rare to find an ACD of this amount. And ACD should be 3.0 or more, and the minimum cutoff should be 2.8, nothing less than 2.8. Now look at the white to white. The white to white digital is 11.9 and with pentacam is 12. So if it is 11.9 or 12, we look at this map. इसको जरा magnify करना, इस वाले को. So this is the chart by which we calculate the size of the ICL. Now I am choosing this 11.65 to 12.03. So this is where my 12 will come, or 11.9, and the size of the ICL will be 13.2 millimeters. So we have decided this is a parameter. 13.2 is the size, 11 minus with plus 2.5 at an axis of 85. Right, this is the calculation. Now we come to the patient, but before the patient, let me tell you that there are 2 ways to mark the axis: the manual axis and or the digital axis. More and more, as we are doing more and more torics in cataracts, my cataract toric rate is almost 70%. ICL toric rate is almost 95%. Even for half a diopter, I am doing a toric ICL. So more and more the ICL, the torics I do, I am very comfortable with the digital method called the Varion. So here is the Varion. I am doing the left eye. I am sitting on the left. Can you show this closer up? I am sitting on the left, and the axis plan is 175. So this is the screen which is going to show me that the axis planned is 175. Now coming to the eye. Okay, now this patient, if you see, there is a ring there. This ring is of the Varion, and I am going to mark with the Varion a blood vessel which the Varion has already collected data in the Varion machine. So capture karo.
Yeah, Dr. Sanjay, I will just request you to keep on telling about the people who don't have Varion.
Yeah.
They should do the marking.
Perfect.
Yeah.
So the Varion has captured the data. I'll talk on both the sides. So Varion has captured the data, and if I reduce the magnification, you can see next. So this is 175.
Important. Centering of the eye is very important.
Yeah. So now this is at an axis of 175, and I'll just mark this axis. So all through the procedure, I don't have to keep an eye on the Varion. Light पे देखो जरा भैया, थोड़ा सा, हाँ. So this is where my axis is. Okay, उसको हटा दें. Now there are two ways to develop your axis. You can go the manual way. The best way, if you have to go manual, is the axis reference marks of 0-180 on the slit lamp. But that takes a little time because you have to go from one machine and then to bring the patient to the table.
Yeah, in Varion we don't need referral marking, correct?
Yeah. And the second best way is the bubble marker. So bubble marker, the patient is on the table, you mark the reference marks there only and ask the patient to lie down. And the third option is the digital, where you don't need reference marks. The Varion checks the blood vessel, which is the most prominent, gives an angle to it, and from that basis it decides the angle for you on the eye.
Because referral marking is always done in the sitting position, because once the patient lies down, there is a torsional movement, so referral marking will not be 90-180 axis will not be correctly marked.
Perfect. So we move on. So a two-port surgery, the direction should be towards the endothelium, because you do not want to risk touching the lens capsule. So the direction is upwards towards the endothelium. If you touch the endothelium, it's not an issue, but in no way you should be touching.
And one thing more, once we are entering the eye, never press the lower lid, just to avoid collapsing the chamber. It has filled up nicely anterior chamber with visceral latex, so the chances of touching the lens with the blade is very low.
Which is 3.2 millimeters.
Now, like Dr. Sanjay has filled up nicely anterior chamber with visceral latex, so the chances of touching the lens with the blade is very low.
So now, the ICL comes in a bottle like this.
Yeah, the most important part in ICL implantation is the loading part. So loading is the most important thing to be done. So you just sponge.
So you get the ICL out, and if you can see the right leading haptic and the left trailing haptic, they have a hole. So that is how you come to know the right direction of the ICL, and that the ICL is not in the upside down position. So you would have options where the leading haptic can have a hole in the left eye, in the left haptic. So other companies are doing that, and there are some companies which are giving it the leading haptic in the right. So you have to know beforehand the lens you are using and where the trailing hole is and the leading hole is, right? Okay, now this is the cartridge filled with visco. I am placing the ICL here. So this is a siliconized foam. This is the ICL in position with a little bit coming out from the edge of the cartridge. And now to load, with the sponge, I am not holding it in the center, but a little in front of the center, and I turn it around like this, anti-clockwise. And when I turn it around anti-clockwise, the ICL will turn clockwise like a gear mechanism, and it will immediately fall into position. We have realized that a lot of beginners have a problem in loading the ICL. So this technique works very well, and let us see if it works equally well during this live demonstration. So hold it here, press, and it comes in, right? So this is the ideal position for the ICL. So now this is alligator forceps, because it is
special forceps dedicated for the ICL only.
Okay, so this is the mouth of the alligator forceps. It should open up well like it is opening up now. Press it, it goes in through the nozzle, holds the ICL,
haptic of the ICL,
and pulls it into the nozzle. Okay?
This push should be in one go.
Yeah. And you can see that edge there in the nozzle. Okay, now you turn it around.
Very nicely done.
So now this is the injector, and that foam tip is now attached to the injector. Now I am loading this cartridge into the injector. So here, and I turn it in like this. It's clicked in position. Now we are ready to insert the ICL in the eye. Now there are two ways to insert it, under visco or under hydro. Both techniques are very good. The advantage of hydro insertion is that you are not using too much of visco, and whatever strands of visco that are there in the injector, they come out in a few seconds. Whereas if you insert the ICL under visco, then the visco may get attached to the plates of the haptic, and some of it may still stay back and cause a secondary or an early post-op rise in IOP. So an irrigator, if you see my parameters, the IOP is at 40 on the screen. So low IOP, and this ICL is in position, and
like this is important, like below the irrigation we have to implant.
Yeah, so you see it opening out, this is how it should open.
Any rotation.
It's about 2/3 in or 3/4 in, then you can let it open slowly, and the ICL is in position. Right. Now you can see a central hole. You can see the axis mark. There is one axis mark here, one axis mark here. Now what I am going to do is, whatever little visco was there which came in with the injector, just in a few seconds that visco is out. I don't have to run after all of that, just little. So that's it. And I am ready to go to the next step. That is the advantage of inserting it under hydro. It's not about time, it's about visco, which is easily removed. Now, before I tuck the ICL into the required position, I have to bring the ICL and align the axis marks. These are the axis marks to the axis marks on the cornea. So these are aligned, and now I have to start the tucking process. So एक जरा marks दिखा दे, वो दिखा दे, vary on. So now या थोड़ी देर हटा दे, let me show it without that. हटा दे. So first the distal one, and press and tuck. One gone. Simple. The second one, tuck, 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 and twist, and it goes into the eye. Second gone, and it is on the axis mark which are shown on the cornea. Now you are coming to the third one. So this one first, grab, 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 get to the periphery and tuck. The third in position, and with the left hand I am ensuring that the ICL does not move out of its axis. And then the fourth one, grab, grab, grab and tuck and in position. Now see, I have tried my level best to keep the ICL on the axis. It looks on the axis, but let's confirm it with the Varion. Check.
Yeah, this is one of the excellent way of putting the toric IOL along the axis, because once you engage the ICL below the iris.
Okay, so the idea was to show you actually almost unedited some very basic steps so that ICL implantation is actually not very difficult. It is simple. The steps are simple. So this just gave you an idea how you could go through these steps simply. There was actually no struggle, nothing. And since it was almost a live continuous performance, you could actually see there is no magic from behind. They are just simple steps to put an ICL in the eye. Thank you.
Thank you, Dr. Sanjay Chaudhary, for that wonderful demonstration. And now let's hear it from the young surgeon perspective. We have none other than less a young surgeon with us, Dr. Supriya Sriganesh. Congratulations to Dr. Sriganesh and Supriya for being with us, and thank you so much. So let's hear from a young dynamic surgeon what she has to say.
Thank you so much, sir. So good afternoon to all my teachers, my colleagues and friends. I'm Dr. Supriya Sriganesh, and today I'll be talking to you about how to start your ICL practice. I've only been implanting ICLs for a few months now, and I'm going to tell you what sort of setup you require to begin implanting ICLs from my perspective. So why begin your ICL practice?
Her slides are not moving. Can somebody help her?
It's not correlating. It's not coming.
In the meantime, she sets up her PowerPoint. I want to add 2-3 pearls. Why make a marking, Dr. Sanjay, once we are doing totally a digital alignment of toric ICL? And another pearl, just let me come. Okay, all right.
Yeah, Supriya, all to you.
Sorry about that. Yeah, it's working. So to begin your ICL practice, you don't need to purchase a lot of specialized equipment for the same. It's a low investment refractive surgery. It's reversible. The cornea remains untouched. There's a quick learning curve for anterior segment surgeons who are already doing phaco. And that post-op day, one wow factor is unbelievable because the corneal aberrations are not much. The recovery is very quick. And it's ideal in patients who are unsuitable for keratorefractive procedures. And that post-op day 1 factor that I was talking about, that wow factor, is added to by the higher effective optical zone, and in high myopes, it reduces the minification. So initially, how do I select my initial patients? The refraction should be stable for at least a year. The ACD should be greater than 2.8, ideally greater than 3 mm from the corneal endothelium to the lens. It corrects up to -19 to -20 diopters of myopia and 4 diopters of astigmatism and 9 to 10 diopters of hyperopia. You need a round pupil, open angle of the anterior chamber, a clear lens, a normal IOP, no other ocular pathology, and no previous ocular surgery. So for beginners, this is a good way to start off. Of course, there are much more complex scenarios like Dr. Ramurthy elaborated that we can implant ICLs, but for a beginner, we would start with the simple cases. So what equipment do you need to begin the practice? So your very basics, such as your slit lamp, your indirect ophthalmoscope, your 78 to 90D lenses, tonometer. Every patient needs to undergo gonioscopy, retinoscopy, a very good retinoscopy, both subjective, objective and dilated refraction, a pupillometer, and an ultrasound biometer with a pachymeter is enough. The auto refractometer and keratometer, a digital caliper, and a topographer. So among all of these instruments, your normal cataract practice would have everything except probably your digital caliper, your topographer, and your pupillometer. But is a topographer really required? Like Dr. Sudarshan elaborated, the digital caliper is one of the most simple and accurate methods of measurement of your white to white. The topographer basically confirms that measurement, and also every refractive practice requires a topographer, and it's also very helpful in ruling out your keratoconus cases. So again, your OBSCAN is a very good topographer to actually measure the white to white. It has one of the most accurate measurements, but in some cases it can give you a wrong measurement. So there's a tool called the iMetrics tool where you can manually correct and measure the white to white. So it gives you a correct value. Now, in an ideal setting where you can have anything you need, what are the additional equipment that you may consider purchasing for your ICL? So we have the MS39, which gives you a very high resolution anterior segment OCT, along with topography. You have your UBM, which was spoken about, which gives you your sulcus to sulcus, and it also gives you the simulation of how the ICL would look in your sulcus to sulcus, which helps you with your measurements. Your ASOCT, which again measures your lens rise and angle to angle measurements. Pentacam, of course, for topography. Again, Pentacam may slightly overestimate the white to white. Specular microscope for the endothelial counts. In very young patients, you need to make sure that the endothelial counts are 3,000 to 3,500, and your minimum should be about 2,000. The IOL Master 700 again is for your biometry, your axial length, your anterior chamber depth, but IOL Master 700 also is known to overestimate the white to white. And your eye trace for the aberrations, again, like Dr. Ramurthy explained about in highly aberrated eyes, it may not be a good idea to go ahead with the ICL. So just to rule out highly aberrated eyes where you would rather do a wavefront guided LASIK, and also for postoperative patients where you want to rotate your ICL, it can be useful. So in our center, we have this form where we take all the measurements. So as you can see on the left-hand side, you have your ACD, where 3 measurements are taken. 3 measurements of the white to white are taken, both for the right and the left eye. And the iMetrics tool on the OBSCAN is used for the white to white measurements. Your K1, K2 has to be entered, your corneal thickness, and your refraction for both the right and left eye. And here you can see some of the values C1, C2, C3. This is actually obtained from your UBM, which I'll come to a little later. And then your anterior chamber angle and lens rise is also mentioned in every sheet in our workup. So this is a small video just showing you how our patients are worked up in our center. This is the auto ref which is done, which can also measure the white to white. The refraction, nothing beats your retinoscope, but it's just confirmed by this refractive surgery setup. This is your Pentacam. 3 continuous readings are taken from the Pentacam. And the white to white is, of course, again correlated with your OBSCAN and your calipers. Then the patient undergoes MS39 after the Pentacam. Mainly the ASOCT on the MS39 and the tear film analysis helps us in such patients. Then the optometrist actually measures the sulcus to sulcus measurements and the lens rise on the ASOCT. And then we do the UBM. With the anesthetic, the shell and the UBM is done. And after doing the UBM, it takes multiple readings, and the white to white is measured using digital calipers. This is the simulation. So coming to how to choose your ICL. So the STAR ICL has an online software where you have to enter all the patient details. On the left side, you can see all the patient details, including white to white, the corneal thickness, anterior chamber depth, K1, K2, etc., which is all entered on the left side here. And it gives you the options for your ICL, including the expected spherical equivalent, where you can decide the options for your ICL. And also, based on the simulated, both the ACD, your lens rise, your white to white, your simulated ICL from your UBM, if you want a different length requested, then you can actually choose that different length and customize it. So this is what I was talking about, C1, C2, C3. This is your UBM display. So basically what this machine does is, the software, it actually simulates for each size of ICL. So on the left side, you can see there are 4 sizes of the ICL, which was again spoken about earlier. For each size, how much C2 is the central vault and C3 is the mid-peripheral vault, which is actually more important than your central vault. So it actually tells you how much your vault will be for these particular sizes. So this can help you make the decision regarding your ICL sizing. But of course, this doesn't take into consideration your lens rise. So again, they have an inventory from which you can choose your ICL. And finally, you get this implantation orientation diagram, which was explained by Dr. Tityal beautifully. Here we can rotate the lens either counterclockwise or clockwise, and the maximum you should rotate the lens, it should be within 22 degrees. So speaking a little bit about the ICL itself, it's available in these powers, and it has the thickness of the center optic is just 50 microns. So for surgeons who start off after doing cataract surgery, that mindset of manipulation only in the center needs to be changed to manipulation only in the periphery, because the central optic is very thin and can be damaged. And in the V4C model, you have a 360 micron center, the KS central hole, the KS aqua port. So coming to what surgical setup do you need? Limbal marking systems were again spoken about. The markers and the automated limbal marking systems. And these are the extra instruments that you may need for the actual manipulation of the ICL. So you have the Dietz Tucker, you have the Vukich manipulator, you have the Palicaris olive tip positioner, etc. In our setup, we used something called the Ganesh ICL manipulator, which was designed by Dr. Sri Ganesh. This is actually a visco cannula, which has a manipulator at the end. So as you're injecting viscoelastic, you can manipulate the ICL with the same instrument. So there is much less instrumentation in the anterior chamber. And the same instrument can be used in a single main wound, and the side ports don't even have to be made. So the other instruments, the foam tip applicator, the importance cannot be stressed enough. It has to be well hydrated to avoid overriding of the applicator, and the injectors are required, and the pull-through forceps or the alligator forceps. So this is just another video of loading of ICL. You have to inject normal saline and viscoelastic, after which the ICL is taken out through the foam tip applicator and placed within the grooves of the cartridge using the foam tip applicator in a convex fashion. It's then, the pull-through forceps is then used to grasp the edge of the ICL, and the cartridge is pulled back rather than pulling the ICL forward. This is a cartridge into which the foam tip applicator is then placed and locked into position. You can actually hear and feel a click, and the ICL is loaded, the cartridge. So this is a technique by which just a single 2.8 mm incision is made, and the ICL is injected via that. No other side ports are made in this method. But for beginners, of course, 3.2 mm incision is ideal with 2 side ports. Then the ICL is tucked into position. So what do you see post-op? So in your post-op picture, it's very, very important to compare your vault size to your corneal thickness. It should be between half to 1.5 times your corneal thickness. So this is what a normal post-op eye looks like, and this is what your high volt and your low volt looks like. On the left side, you can see the distance between the lens and the ICL is very large, and on the right side, you can see a very shallow vault.
Supriya, I would request you to just summarize. Please.
Yes, I'm just ending with this one tricky situation that we may face of the ICL getting injected wrongly. So here it's flipped over inside the anterior chamber. It's actually injected in the wrong orientation. So in this scenario, it's very tempting to try to flip the ICL in the AC, but then never do that. Enlarge your incision, make it a trapezoid incision, and with your pull-through forceps, you can go in, grasp the ICL in the center, and with a twisting, pulling motion, just gently explant it, and then the same ICL can be reloaded and injected in the correct position. I'm just going to skip ahead. It's the same ICL is injected in the correct position, and so we end the case here. And I'm almost done, sir. Just take home message. ICL is a great way to begin your refractive practice with very low investment. Start with the essentials and go from there. Thank you very much.
Thank you, Supriya. So we have Dr. Rahil Chaudhary, and let's hear from him some marketing tips, and none other than less, Rahil would enlighten us on this.
Slides बंद करो. Yes. So we are already past 1:30, so I'll quickly summarize this presentation. So we are talking about marketing in 2022, and I don't think there's any other tool to market today apart from social media. So don't waste your money on print, don't waste your money on TV ads. Nothing works, only one thing works today, and that is the social media. And when we are talking about social media, we are primarily talking about only 3 platforms: YouTube, Facebook, and Instagram, where YouTube can do wonders and Facebook and Instagram are basically to support your campaign. So YouTube is the new Google. People have stopped Googling now. 80% of the traffic today is on YouTube, and that is where you want to be. So this is one of the days on YouTube, and you can see in one day I'm reaching 31 lakh people. In the last 48 hours, 31 lakh people reached in 2 days. So this is the power of YouTube, where I see most of you are missing on this. So this is approximately 1,000 people checking me out every minute of every day. And YouTube gives you a potential to reach all your subscribers. So you put anything there, it instantly reaches out. So I have about a following about 7 lakh followers on YouTube, and instantly I'm connected to them at every moment. And there are varied contents that you can keep putting on your social platforms. So you have surgical videos, patient testimonials, awareness information. So they are just some examples where some of the videos can almost reach viewership about 15 lakhs. And this was a live session of ICL that we conducted, reached about 1 lakh. Testimonials of patients who've come in for surgeries, awareness videos. So basically, I wanted to discuss about how to get around making YouTube videos. So people feel that it's very complicated, very difficult. In fact, this is the easiest way to do it. You just need very simple equipments to start your videos. You need tripods, you need some basic simple backgrounds, a phone with a good camera quality, some external lights, something to record your audio, and the editing software. So there are multiple editing softwares available online, and most of the softwares are for free. So you can create things for free. Video editing softwares like Filmora are for free, and you have basic tripods available at Amazon costing about 500 to 1,000 rupees. And then of course, once you start with your videos, you can always keep advancing your equipments and keep making better and better videos. So simple plain wall works wonders, but of course you have digital walls where you have a digital screen that can be used as a background, or you have green screens which can again be used. And use a basic mic. Don't invest into very complicated equipments in the beginning. And of course, once you start making videos, you can always invest in advanced mics, wireless wireless mics. And initially you start with basically lit room, and then you can of course add on to your advanced filters, advanced lighting, and then move on with your channel. But most of the people think that making video is only part of the journey, where you have to understand that there's something called as YouTube SEO, where you actually have to put in a lot of money for your videos to get that viewership. So but of course the more money you put on YouTube, the more viewership that you get, YouTube rewards you back. So I'm earning about approximately 1.5 lakh rupees per month just from YouTube, just from the viewership of the videos. And content is the king. Don't try to copy. Usually I see people see 4 different videos, they pick up points from there and they make their own video. That is not going to work. YouTube has artificial intelligence. It knows what you are searching, it knows what you are making. So don't try to do that, it will never work. And then of course you have this organic reach, and then you have...
I would just request that we have a Colonel Rangacharya
yes,
award
yes,
to
I
follow.
think I would...
Session. Yes,
yeah,
so wonderful. I know that we all need this. Just please sum up and thank you.
Yeah, so basically the idea is that forget the other means of marketing, just get onto social media and you will see wonders happening to your practice. Thank you so much.
So thank you very much for being with us in this star session. I think we addressed everything right from the beginning to the end. Thank you very much. So let the next session, I would request the Colonel Rangacharya Award, the judges to be there. Please.